let's go ahead and talk about our week 6 ALG. This is about health and wellness, okay? We start off with a couple of definitions here. Our definitions are something about primary amenorrhea and secondary amenorrhea. Primary amenorrhea is when the menstruation has not started by the age of 16. If somebody is experiencing primary amenorrhea, it's important that they go and see a healthcare provider to, one, make sure they're not pregnant, even though they might tell their mom or their dad that they're not sexually active. You definitely want to make sure they're not pregnant, but also do they have anything else going on that could cause their period to be so late? Secondary amenorrhea happens when a previously established menstruation has stopped for longer than 3 months. This can be due to different reasons. This can be due to a hypothalamic dysfunction, i.e. anorexia. When somebody is anorexic, they have low body fat, and the estrogen is kind of stored in the body fat. And so when you have low body fat, your periods can stop. Runners, athletes, again, low body fat, again, it's not uncommon for the periods to stop. Or pituitary dysfunction. There are some dysfunctions of our pituitary that can cause secondary amenorrhea. Again, really important to follow up with your healthcare provider so we can make sure that everything is okay. Another definitions, if we're going to talk about here, is dysmenorrhea. Dysmenorrhea is painful periods, painful menstruation. Okay. Primary dysmenorrhea is when there's painful menstruation caused by increased prostaglandins. Over the last few recordings I've done with you, I know more than once I've talked about how prostaglandins cause irritability. I talked about it specifically when talking about doing a cerclage placement and how you put a stitch through that cervix, which releases prostaglandins, or how semen can also have prostaglandins. So prostaglandins cause irritability in that uterus, and so it causes pain. That's primary dysmenorrhea. Secondary dysmenorrhea is when there's painful menstruation caused by issues with the reproductive tract. Things like pelvic inflammatory disease, otherwise known as PID, and endometriosis. Okay. So what's next? Let's talk about contraception. So I will say contraception is a big bulk of this lecture. And as much as people love talking about babies and love talking about being pregnant, not everybody loves talking about birth control, but it's something that should be included in this class. I'm very comfortable talking about it, so I'm going to talk about it here with you. So yes, unless you're an advanced practice nurse, which I am not, and you are not in a program currently to be an advanced practice nurse, but unless you're an advanced practice nurse, you are not writing prescriptions, but you know that your patients are going to trust you. So they may ask you questions about contraception. It's really important to establish trust with your patient and the family if that's applicable, but it may not be. It's important that we as nurses understand the risks and benefits and alternatives. Involve both partners if appropriate in the teaching. We need to be aware of our own biases. We talked about that last week. And always be considerate of the cost and the age of our client. Just because somebody has good, quote, good insurance doesn't mean that their insurance covers birth control, right? So it's important that we're aware of these things when we are going to be talking to our patients about it. We're going to discuss measuring basal body temperature. So your patient needs to understand how their body works. So we need to understand that when the time of ovulation, the temperature decreases just a little bit before ovulation and then rises during ovulation. And the fertility is going to extend through 3 days of temperature elevations. The person who does this requires lots of patience and commitment. It requires measuring your temperature every single morning before you get out of bed. So next to the bed, they need to have either their phone, if they're going to put their notes on their phone, or they need to have a piece of paper and a pencil and a thermometer. Okay. So before they get out of bed, they wake up, reach over, grab the thermometer, take their temperature, and document it. And you're looking for trends, right? You're trending it out. So again, understanding that just before ovulation, there's a slight decrease in the temperature, and then it's going to go up. And if you're trying not to get pregnant, you don't want to have sex during those elevations in temperature. Okay. So the advantage of this doesn't cost anything, right? Except a thermometer. And no need to take any medications, right? You're just taking your temperature and trending it. The disadvantage is it requires a whole lot of consistency. There's a high risk of pregnancy, and there are many things that can influence our temperature: stress, fatigue, electric blankets, being sick, those kinds of things. Okay. And there's no protection from STIs. So that is one natural way of preventing a pregnancy. Okay. So next we're going to talk about a male condom and a female condom. A male condom is more readily available than female condoms. You can buy male condoms anywhere: 7-Eleven, the grocery store, Target, Amazon, of course. You get everything in Amazon. Okay. So a male condom, so it's readily available and it's small, so you can keep it wherever you want to keep it. It must be placed on an erect penis and it comes rolled up. And so what you're going to do is you need to stop in the middle of what you're doing, go somewhere, get your condom, open it out of the package, and roll it onto an erect penis. So there's a little bit of an abrupt halt in whatever's happening between the two people. It can be used with spermicidal jelly for added effectiveness. Okay. It can be made of latex, rubber, or polyurethane, and they are single use. You do not reuse these. So they're readily available. That's a really nice advantage. I mean, just go down the street to the grocery store if you want to. They don't cost that much. They protect against STIs, and there's no need for prescription. Those are all good things. The disadvantages, as there is a reduction in spontaneity. You have to stop what you're doing and get the condom. Okay. A female condom is similar, right? I mean, it looks different because our anatomy is different. So a female condom, and again, you can look it up online for pictures. There's tons of pictures online of all of these things. And I have pictures in the Arise modules too. They're everywhere. So I will leave you to look it up if you want to. A female condom is a vaginal sheath that goes inside the patient's body, okay? And there's flexible rings on either end. It is a closed system, and the only open part is the part that's by the labia, okay? It comes rolled up, and before you have used it, you have to kind of pinch it and then put it in. And then there's a skinnier ring that goes against the cervix. You've got the barrier that goes along the side of the inside of the vagina, and then a bigger ring that lays at the labia. And that's the opening, okay? That's how you do it. Some of them have like a little, not really a straw, but like an applicator to put it into. It just depends. Advantages. I would not, and I didn't write it. I don't think they're readily available. You can get them at Amazon, but you can't get them at the grocery store. You can't get them at 7-Eleven. So they're not as readily available, or at Target or all kind of, I've looked just because I'm curious. They typically have male condoms over female condoms in places. Anywho, so the advantage is that there's STI protection and in the prescription. Those are good things. But again, the disadvantage, just like the male condom, and there's a reduction in spontaneity because you have to stop what you're doing and put this in. I will say it looks to be easier to put a male condom on versus a female condom, but that's up to you guys to decide. Okay. We're gonna go ahead, and there's a bunch of other kinds of birth control in your book. I'm not covering all of them here because again, that's not my job. My job is not to cover everything in your book. I'm just hitting on some highlights here. So next thing I want to talk about are birth control pills. So oral birth control pills, you can have birth control pills that have double hormones, which is estrogen and progesterone, and you can have birth control pills that have just progesterone. The essence, they do the same thing, but there's less hormones in the one that only has one. That makes sense, as opposed to two, right? So let's talk about the combined birth control pill. So your combined birth control pill has both estrogen and progesterone. I just said that. The action, like if you're in a pharm class, it's going to ask you, what's the action of this medication? The action of this medication is that it suppresses ovulation. It keeps your client in an anovulatory state. Okay, that's one of the things it does. It also thickens that cervical mucus to block the semen, and it alters the lining of the decidua to prevent implantation. As you know, when you've got an embryo or blastocyst, depending, trying to become implanted in the side of the uterus, it wants that thick plush uterus, and the action, because of these hormones, makes the lining very thin, so it's not a real welcoming place for implantations. That's how it works. So what's the advantage? Well, if you take it correctly, the correctly means same time every day. Set your cell phone, give an alarm. If you take it correctly, it's highly effective to prevent pregnancy, which is great. That's what we're trying to do, because it keeps those hormones at a therapeutic level. If you take it every day at 9 a.m., it's a therapeutic level. But if you don't, if you forget and you take it at 9 a.m. and 4 p.m. and 3 p.m. and 8 a.m., those levels are going to be like this, right? It's not that therapeutic level. And when you've got these peaks and valleys of these hormones, your chances of having a pregnancy happen are higher. So you want to make sure that you take it at the same time every day. Also, because you have the combined hormone birth control pill, there's a decrease in menstrual bleeding, okay? So the estrogen really kind of is the anchor for menstrual bleeding. And so when you have a birth control pill that has estrogen in it, you're going to find that your patient or whoever you know that's taking it is going to almost have their period up on the same day every month. Okay. And how they work, there's usually a pill pack, most often a 28-day pill pack, but you can get 3-month or 6-month pill packs. Let's talk about a 28-day pill pack. So you start them on the Sunday after your period, and there's 7 days. It's like a little square or a circle. The circle is just a big circle, but if it's a square, there's 4 rows, 7 pills in a row. Start it on a Sunday, take it the same time every day. So the first 3 weeks of your pill pack, you have hormones going in your system. The last week, those are placebo pills. There's nothing really in those pills. It just kind of keeps you on track. And that's when this patient's going to have their period. And again, if you're taking the combination estrogen and progesterone pill, you're going to find that the estrogen really kind of ties that menstrual cycle down to be on the same day every month. It also decreases the amount. It is not uncommon that somebody who's taking estrogen and progesterone birth control pill have a very small menstrual period. Okay? All because of the estrogen. It can protect against some kinds of cancers as well. So that's an advantage. The disadvantage is there's really no STI protection here. It requires a prescription or some kind of visit to a healthcare provider. You can go to Planned Parenthood. Not always covered by insurances, just depends on what kind of insurance the person has. You have to really be on it. Take it the same time every day. If the person's like, I'm really not that good of a planner and I can't take it the same time every day, then this may not be the right thing for them. That's why it's important. I kind of led off this conversation is to understand where your patient is coming to the conversation at and then meet them there. Okay. There's a risk of thromboembolism, and that's kind of something we need to know here. Some medications, things like antibiotics, can make our birth control pill not effective, so they can get pregnant. I've taken care of many people who were on the birth control pill who came to me 9 months later and were in labor because they didn't ask the questions. And they assumed that their doctor would tell them. Don't assume, ask the question. All right, let's talk about ingestible, nope, that's not what I meant to say, injectable progestin, otherwise known as Depo-Provera, if you might be recognizing on that. That's a form of birth control. There's just progesterone in it, so there's no estrogen. All right, include the action, advantage, disadvantages. This is exactly the same as the one above. So the Depo-Provera, your client gets an injection every 11 to 13 weeks. And if they go and get these injections, this is very good at preventing a pregnancy, which is just lovely. All right. So how does it work? It suppresses ovulation, puts us in an anovulatory state. It might not be as strong as the combination birth control pill because there's only one hormone. The estrogen's not here. It thickens cervical mucus to block the semen, and it thins the uterine lining. So that's the same. So the advantages, it's a great way to prevent a pregnancy. The nice thing about it, if the person is trying to breastfeed, they can't be on the combination birth control because the estrogen will dry up the breast milk. So if your patient is in the postpartum period and they want to take a birth control pill or get an injectable progesterone, this is the one they want to get. All right. Does not protect against STIs. With progesterone only, I have the hiccups, excuse me. With progesterone only birth control, whether it's an injectable or a birth control pill, there's an increased risk of weight gain, acne, and irregular vag bleeding. And remember, the irregular vag bleeding is because there's no estrogen component in there. So that's what the explanation about that. If they're taking injectable progesterone, like the Depo-Provera, because they only go in every 11 to 13 weeks, if they get their injection, you're not supposed to rub it, just leave it alone after they give it. And then with the understanding that fertility can be delayed up to 18 months, right? Because it's a long-acting injection. What do I have next? The IUD, the intrauterine device. All right. An IUD is a device that's inserted into the uterus by the healthcare provider and left in place for 3 to 10 years, depending on the manufacturer and the type of the IUD. You can have copper IUDs and hormonal IUDs. Copper IUDs, they look the same. Copper IUDs release copper ions, and they're toxic to sperm into the uterine activity, and that's how you prevent a pregnancy. The hormonal IUD, it's progesterone, no estrogen, and it suppresses ovulations, just like it says above it, thickens cervical mucus, and thins the uterine lining. That's how it prevents a pregnancy. It is the most effective form of birth control because there's no user error. You don't forget to take a medication. You don't forget to go in for your injection. You put the medication, the IUD in, and we're good. The contraception is immediately reversed upon removal. You pull it out and you get pregnant. It doesn't affect ovulation. I mean, it does to a point, but it's pretty reversible. So a couple of things about an IUD. An IUD is not always covered by insurances, even the quote good insurances. It needs to be put in with the healthcare provider. Again, your doctor, your nurse practitioner, your Planned Parenthood, however you want to go. IUDs are put in when someone's on their period. The reason is because when your period, your cervix is dilated a little bit, makes it easier to get the IUD in. Okay, so you can expect that. In the beginning, there's, I call it like a little break-in period, but that's not what the books call it. But because your body's kind of getting used to this IUD in your body, you can have irregular vaginal bleeding and spotting. Okay, and that kind of goes away after a few months. Does not protect against STIs. There's an increased risk of bacterial vaginosis. And I don't really have tons of evidence why. I can tell you what I think, but I don't have tons of evidence why. So when you've got an IUD, it's a little tiny T-shape like this. I mean, it's honestly this big. And so there's a little small string that hangs out, and that comes through the cervix. It's always there. The patient has to go in once a month and check, put a finger inside their body and check to make sure they feel the string. If they don't feel the string, they got to call their healthcare provider. Maybe there's an increased risk of bacterial vaginosis because the string is there and bacteria goes up. I don't really know, but that's what an IUD is. Okay. What's next? Oh, toxic shock syndrome. Some of you might know what this is. You'll see there's definitions of toxic shock syndrome and conversation about this on boxes of tampons. Okay. So toxic shock syndrome defined, it's a rare complication of bacterial infections. Staph is the most common bacteria which causes it, and it can affect both genders. Risk factors are having some wounds in that area, the perineal area. The use of those super absorbent tampons and use of menstrual cups can also lead to toxic shock syndrome. Somebody who has toxic shock syndrome develops a sudden high fever, vomiting, hypotension, and a rash that looks like a sunburn. If it's left untreated, it can lead to infertility. So we want to make sure that we educate about that. All right, so rounding out this ALG is perimenopause and menopause, because we've talked all about, coming into our childbearing years, the childbearing years, and now we're coming out of our childbearing years, all right? So what is perimenopause? So perimenopause is the time before menopause when a client moves from normal ovulatory cycles to a cessation of their periods. It can last 2 to 6 years prior to menopause. So we're talking in their 40s. Not everybody experiences symptoms. The symptoms are the same as somebody in menopause, but not everybody has to deal with this. But if it does happen, it happens in the mid to late 40s. Menopause occurs when there are no more follicles left in the ovaries, and it occurs between the ages of 50 and 52, okay? It's caused because the estrogen has rapidly dropped, all right? And so that's really what's causing all of the issues that these people are experiencing. Not everybody, no, I'll get to there. So conditions. So what are some of the things you're going to feel when you're in perimenopause and or menopause because of that drop in estrogen? Hot flashes, mood swings, sexuality changes, decreases in libido, thin skin, osteoporosis. To decrease the risk of osteoporosis, we should do weight-bearing exercises. That's super, super important, okay? a change in vaginal secretions. So people oftentimes will have to use lubrications if they're having sex, and an increased cardiac risk for cardiac disease and stroke. So things can happen. Now, not everybody wants to treat. So the most common way to treat menopause and perimenopause symptoms is to give the estrogen back, because that's the lack of it is causing the problem, right? So you figure if you have a lack of something, let's give you something to fix the problem. But not everybody wants to treat it. So it's up to the patient. It's their call. Some want to just, they can deal with the side effects of it and they move through menopause fine, and some don't. All right. So estrogen comes in many forms: pills, patches, creams, all kinds of things. Okay. And it is the most effective way to treat the symptoms that come with menopause and sometimes perimenopause too. Because again, it's caused because the estrogen drops. So if you give the estrogen back, ideally the symptoms go away. A couple of things: if your patient has not had a hysterectomy, so say they have their uterus, they need to make sure that they don't take estrogen all by itself. You have to combine estrogen and progesterone, because otherwise they can have a risk of developing cancer of the reproductive organ. So that's super important. You can also take low dose antidepressants, gabapentin, other kind of things to help with perimenopause and menopause.